Welcome to the CodeCast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hi, everyone, and welcome to the CodeCast Podcast. My name is Terry Fletcher, and I'm happy to say today that we hit 30,000 listeners. So I'm very excited about that. Whenever I hit a milestone, it just makes me happy, makes me realize I'm doing the right thing by continue to stay on the air. And I just enjoy this every week. So thank you to everybody out there. And just a reminder, if you wouldn't mind doing me a favor, if you found us on YouTube or iTunes or Spotify or Stitcher Radio, any of those, if you could leave us not only a rating, but also a nice review, we would really appreciate it. Keeps us on the air. iTunes loves that, and they actually replay them and put us on certain lists. We hit number one in the healthcare field for business, and so we want to stay at number one. So it's just on a search mode. So if you could do that for me, I would be truly appreciative of that. And so how's everybody doing? So it definitely is winding down to the end of the year. This will be my Christmas episode. So Merry Christmas to everybody who's out there. And in that, keeping with that theme, today I'm actually going to talk about things where you should just say no. How many of you overspent? Okay. How many of you said, oh my gosh, I can't believe I got all my kids that kind of, presents, and I went a little bit crazy with my family and my friends. And I want to keep with that theme. We sometimes overspend, overdo, don't really pay attention to regulatory issues, and we want to be best practices. And so there's some things that have come up over the last quarter, and I want to get into some things that just kind of give you some refocus as we head into 2019. And so in keeping with that today, that's really going to be the spirit of my discussion, and some things that you should just say no to that will not help you, will not make you money, and will just hurt your practice. Some things that I want you to take a look at, making sure that you understand when there's a landmine out there for you, and just some regulatory issues I want you to just be mindful of and stay away from. And then just being flexible and understanding what you need. And then also with vendors, I'm considered a vendor, I suppose, because when somebody hires me, either as an educator or as an auditor or as a management consultant in any capacity, or even as a waiting room designer, what kind of flexibility and accessibility do your vendors have? And so again, with keeping with that, you need to hire what you need, not what you think you can get. And so I want to talk about that. But first, today's CodeCast podcast is brought to you by Movado Watch Company, one of the world's leading watchmakers. Movado, modern, ahead of its time. Movado.com. And Simple Health Radio, discussing topics related to your health and well-being. SimpleHealthRadio.com. Okay, so the first thing that we just want to say no to, and this one, oh my gosh, this has been coming up lately. Like somebody's trying to smack me in the head with it. And I keep saying, don't do it. So here is a friendly note to just warn your colleagues, your friends, your family, anybody that is in the healthcare field. Never enroll in virtual credit card payments. Basically, the payer will send you a payment in the form of a document. It kind of looks like you got a check that was deposited into your bank account, and you have to zip off the sides, but that's not what it is. It's through the mail, and it looks like junk mail. And when you open it up, it has a secret code. And basically what it does is you have to send them your credit card number, and then they send you this document with not only your number on it, but a secret code. And then you have to type that code into your credit card system. Then it takes another 2 to 4 days to get your money, and you pay a hefty fee of anywhere from 5 to 9%. Also, when you enroll with a new insurance company, a new insurer, they basically, the number one option is they say, choose your enrollment type. And it's almost like they're defaulting that you're going to enroll in these virtual credit card payments. And this is probably the biggest revenue producing opportunity for insurers, because most of these documents are never used, or they'll be lost. And if they're used, you do incur more fees from your merchant service provider as well. Not only do you to get your money that way, you take a hit from the payer, but also from your credit card company that you process your payments for. So please don't do that. You want ACH, which is the automatic transfer that goes into your account, or you just want them to send you a check. So you do not want to do that virtual credit card. Just say no. And then we get into some of the things that I was mentioning before about some landmines that have come up. Some of these are going to be focused really on some cardiology issues, but there's also some other specialties that can probably take something from this as well. The first thing, and this is kind of my top 10, but the government has told me and they've posted this several times on the OIG website, that they are spending approximately $1.8 billion to audit and prosecute healthcare fraud this year. And to just minimize your risk, and you need to become familiar with some of these, what we call landmines. And they're faced by a lot of different specialty practices and offices, but no more than the cardiologist or the electrophysiologist, pulmonologist, surgeon. And so the first one is claiming that you performed a procedure that is not fully supported by your op report. So you can, you have to keep this in mind if you're an EP physician, for example, comprehensive studies. So you have to have 6 distinct subcomponents, each listed within the description. And sometimes I'll find that the physician isn't supporting all 5 or 6 components associated with one of the comprehensive studies. And they should have probably reported a limited study because they didn't do interatrial recording, or they didn't do right ventricular recording. And so when you see some of these services, it's hard to support that. The code, for example, 93621 is defined as comprehensive electrophysiological evaluation, including insertion and repositioning of multiple electrode catheters. And this is an add-on code. So you list this in addition to a comprehensive code. But unlike the comprehensive EP codes, they are not associated with subcomponent codes. So for the 2 elements of this code, left atrial and left atrial pacing and left atrial recording, it may not support both left atrial recording and left atrial pacing. And so you would have to attach a reduction modifier to say that you really didn't capture all of it. The other thing I find sometimes is, as far as not saying that you did it, but not finding it in the report, is when there's an implantable cardioverter defibrillator. Traditionally, we've always coded services to include testing the leads. And because, as we know, with the cardioverter defibrillator, it's a pacemaker type system, but when the pacing or there's an abnormality with the heart, it sends a signal to the brain and the heart and says, stop doing that and do it this way. So it kind of recalibrates. But because we have such high-tech services now, we don't have to test before or after implant and connection to that device. And so that's where sometimes I'm seeing it coded, but then I see it nowhere in the report. And then reporting confirmatory tests as diagnostics. Oh my goodness. So when you talk about this procedure or this kind of thing, it's really about making sure that you're understanding the rules and regulations. Diagnostic tests performed strictly and routinely to confirm the success of a surgical procedure are considered to be a component of the surgical procedure and not separately billable. So if you do a study followed by a drug infusion, just to confirm the success of, let's say, an EP ablation procedure, that's not billable. Or if you do an intravascular ultrasound following a stent deployment just to make sure it worked, or what we call, if you do a heart cath that, let's say there was a previous diagnostic heart catheterization, but that doctor didn't do stenting. So they sent the patient over to a new physician that actually is the interventionalist. So they do the intervention, but they still want to inject to mark up or set up the stent and where they're at. That's not billable. It's not considered diagnostic. If let's say you're orthopedic and you'll see on the procedure note where it says diagnostic arthroscopy, and then it'll say medial meniscectomy. Well, they open up the knee through a scope and then they perform this procedure with the scope. Well, you can't bill for both because the more extensive service gets billed. You never bill for a look-see. Same with, let's say, an exploratory laparotomy. You open up the patient's belly to see what's going on. You find out that, wow, there's some issues with the small bowel, so we have to do a resection. You would only bill the small bowel resection, not the incidental or inclusive procedure to open them up. And we see this a lot. So try to be careful with confirmatory tests or bundled services, because that can be really an issue when it comes to helping to support what you do. And then when we talk about billing for road mapping with device implants, one of the biggest things CPT instructs on diagnostic venograms, angiograms, any kind of injection of dye, it says you should not be reporting these services when performed for road mapping purposes to facilitate a therapeutic procedure. Remember, a therapeutic procedure means that it's planned. You're planning on going in and doing a procedure. So basically, you're doing maybe an extremity venography to road map the advancement of electrodes, maybe through the subclavian vein and the superior vena cava, and these venograms should not be reported separately. So you just have to be careful of capturing that. I had a claim sent to me today where somebody was trying to code for the pacemaker antitachycardia device programming, but the implant of a pacemaker includes the programming. So again, just try not to overcode for these services. And you can see where I'm going with that. Just say no. One of the things in EP that happens quite a bit, and this is probably one of my biggest, I don't want to say pet peeves, but definitely with EP, is reporting for diagnostic echocardiography for AV optimization. So, when you're dealing with those optimization procedures, especially of a BiV device, they're reporting a diagnostic echocardiogram when the echocardiography is used to guide the AV optimization, then that's not covered. So, when you're trying to achieve that AV optimization, that involves using a thoracic electrical biopedance device. And there's some safety issues there, but it's not something that you're supposed to code for as an echo. Claiming heart cath reimbursement for transeptal puncture. So anytime that you are doing a right heart cath with septal puncture, it includes that opening of that hole in that heart. And unless there is another reason for it that has nothing to do with the puncture, then that's not something that, with the heart cath, I should say, then that's not something that you can code for. The right heart cath in conjunction with the EP services, it's not about the heart cath, it's about the guiding for the EP, and there's not showing a complexity issue there. Now, I've been talking the last couple of weeks about Incident 2 and our non-physician practitioners. Well, I've been telling you how to do things correctly, or at least trying to explain them, and I'm seeing a lot of compliance with Incident 2 and shared visit rules. So really read your Medicare publications to meet your specific requirements in order to secure 100% of the physician fee schedule reimbursement for what was performed by the mid-levels. In the office setting, the physician must be in the office suite and when your mid-level sees a patient and for an established problem. In the hospital setting, both the provider and the mid-level provider and the physician both must have face-to-face encounters with the patient, and each provider must personally document what their visit consists of to be able to bill for that. And I had a question recently that said, well, can we just bill for time for both providers because the NPP spends this much time, the doctor does, and then they collaborate on the phone? I'm just like, no, you absolutely have to have this face-to-face piece, and it's based on documentation. If you base it on time, can you imagine just how ridiculous all the level 5s would be? And then billing for an office visit on the day of an elective procedure. Medicare Claims Processing Manual is so clear about this. It specifies that a preoperative visit provided after the decision for surgery was made, those are included in the surgical reimbursement and not separately billable. So because of that restriction, many surgeons, EP physicians, some cardiologists, they should not report any E&M service on the day of or the day before the device surgery or any surgery. Physicians should not report any visits, on the day that something is planned or scheduled, unless it's completely for a different reason. And don't pick a reason that you're not concerned about to be able to move forward with the procedure. And then that also goes along when we're talking about screening colonoscopies. There's no such thing as a pre-screening visit for a patient who has no complaints. They're there because they're age appropriate to check for colorectal cancer. There's no visit. Okay, so I just talked about this on the update for gastroenterology. So please see my website if you're interested in a webinar on that. But this was a kind of a big one recently. And then claiming compensation for the work of device company representatives. Okay, so one of the things, especially for those of you that are not in the cardiology specialty, when pacemakers and devices such as cardioverter defibrillators are implanted into the patient, they come back into the office to make sure that their device is working correctly. A device includes a generator, which is the battery pack, and what we call electrodes or leads that are attached to this pack that help pace the heart, okay, to make sure that there are no abnormalities or arrhythmias and that it's doing what it's supposed to do. In a defibrillator, it's the same thing as a pacemaker, except when the heart has an abnormality. Typically, these patients have cardiomyopathies and issues. The sensors in that pacemaker will send a signal, as I mentioned before, and change that abnormality into a normal pacing. And so it just depends on the diagnosis of the patient, which one they get. But what happens a lot, device interrogation services have professional and technical components. And the physician's contribution, so supervision, interpretation, report, is the professional component. The technician who operates the programmer and the overhead expense for the facility in which the device is interrogated constitute the overwhelming majority of the technical component. But if you're actually having your device company representatives, which they volunteer to do this because they want your business, it's never appropriate for them to be billed or for a physician to request reimbursement from the insurance company for any device interrogations that they're performing without a 26 modifier. First of all, you have to have the physician in clinic. Secondly, you need to have an employee in the room. Remember, anything that you're billing directly to a payer, you're saying that there's overhead involved, as I mentioned. Well, if you're not paying these salespeople who've been trained on a machine to do these device checks, then you are definitely chalking up the wrong compliance tree, and that can be a problem. So yes, you'll see a reduction in compensation, but you'll be doing it correctly. So that is a huge regulation, and Heart and Rhythm Society also weighs in on that. And the number one issue, and I think is probably because it's one of the most mundane tasks, is documenting in progress notes at the hospital. And, this is the number one regulatory landmine, in my opinion, faced with most providers, because these services are provided with such a great frequency and they're typically documented in such an expeditious manner. But a level 3 hospital follow-up visit has a higher documentation standard than a level 4 established patient visit, believe it or not. And a lot of government auditors, including myself, have stumbled into the fact that a high percentage of these follow-up visit notes do not support the levels of service. And I've seen thousands of audits on this focused on hospital follow-up visits. So it's definitely important for you to understand the applicable documentation guidelines and really kind of understand what you have to do to make sure that you're compliant. And I'm actually going to do what we call a peer review and put it on YouTube as well. But we're going to have something like this for you just so that you can understand how this works. I'm going to have it as in webinar form and then just kind of give you a tidbit on the podcast. But I'll direct you then to the webinar form, and hopefully then through that video, that'll just really help you to understand what you need to do to support those documentation guidelines. So look for that in the new year, because we're talking about 4 recognized descriptors you need of the history of present illness, location, quality, severity, duration, timing, and context, modifying factors associated with the problem. There's all kinds of things that are not being documented and just being brought forward, and the hospital is a place where you have to be very careful with that. Otherwise, there could be an issue. Okay, so I would also like to thank Trident University. Trident is a leading online university serving members and the military, veterans, and corporate. Trident.edu. So I went a little short today only because it is Christmas Day. So everybody have just a really great holiday season, and hopefully you got just enough today that will bring you into a new focus for your compliance manual, that you know that 2019 will be your epiphany of best practices and just really good business behavior. You just want to stand above reproach. We're getting into the MIPS and macro season for your physician bonuses. They're now rated, and they're on a website now for that rating. And so it's important that they are above reproach and we do what's right. So this is our just say no and make sure that you know what's going on, and that you also, with your vendors, also make sure you know who your vendors are. Make sure that you get references. that they are available off hours if you need them. I know I am. I know that, I try not to be accessible 24/7, but I'm accessible a lot more than I'm not. I see a lot of billing companies that say we're not open Saturday and we're open 9 to 5 Pacific Standard Time. That helps nobody. Never go with a billing company that has that kind of lack of flexibility. So we just want to just give you some insight today to hopefully understand where you're headed and what's going to happen in 2019. So we get into 2019, just so you know, my next episode is going to focus on new versus established patient from an auditing perspective. I am going to get into a little bit of endovascular discussion. I know those are really a bear to code, so I want to talk about that a little bit. And then just really kind of revisit some of our topics that people have asked about. Since we have some new virtual visits with Medicare, I want to bring to your attention what that actually means. Not really in a telemedicine, this is what Medicare says, but more that they're now allowing for some communication type virtual services. And we want to make sure that we're really looking at that from a capture perspective. What can we actually do there? And then I want to talk to you about coding and billing collections. I think that we have some really popular episodes about that, and I'll kind of pick on some specialties so that you have some things that you want. And if you are a specialty that you don't think I talk about enough, please send me a quick email at terryfletchercpc@aol.com. I would love to address your specialty. I am multi-specialty, so if I can, I will. And just hopefully give you some insight that you've been looking for, a little tidbit there. So my little personal note for this week, somebody had said, so Terry, you seem to work in your office late all the time. So do you run out and get dinner? What do you do? Okay, so here is something, it's a little embarrassing, but here's something I do. I don't know if any of you have young kids, but you know those Uncrustables, not the grape, but the strawberry. Yeah, I throw 2 of those in my bag almost every day, and they're in my office for dinner. So if I'm in my office, my home office, I'm not traveling, my dinner plans are peanut butter and jelly. So what can I say? I like them, and there you go. So for those of you who are just sitting there rolling your eyes or secretly going, oh my God, I do that too. You know what? Shout out to you. There you go. So sometimes you just make it happen. But anyway, so thanks again for listening in, and everyone, just make it a great day. We really appreciate having you. Thanks for listening to the CodeCast Podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.